Good afternoon, everyone, and welcome to this month's Employee Benefits Compliance webinar. As we are getting started, we are going to kick off with a couple of polling questions, as we often do. You should see those pop up on your screen. With the One Big Beautiful Bill Act having some provisions that impact employee benefits, we are curious about your company's perspectives related to the new Trump accounts, as well as the student loan repayment provisions. Please take a moment and answer those questions. And as you are providing your responses, I would like to again welcome you to today's webinar. I am Jenny Bedeau with AssureXglobal, and today the Loomlight team will be taking us through a regulatory and legislative update. And as we are getting started, we would also like to extend a special thank you to your local benefits advisors and consultants who are partners of AssureXglobal for making today's webinar possible. We do welcome your questions today. You will see a Q&A function at the bottom of your screen. Please submit your questions over to us. We will be monitoring those throughout our time together here today. And I will also remind you, we do record our webinars, and a link to the recording will be available early next week from the benefits advisor who invited you here today. Again, we get that question a lot. So yes, we do record the webinars and check in with that benefits advisor for that recording link. They will also be able to provide you with a link to the presentation slides, but I'll also drop those in our chat section here in just a couple of minutes. And I'm going to let those poll responses still come in. It looks like we've still got some folks kind of answering them. I will also give you a heads up. We do have a couple polls that are going to be deployed during the heart of our presentation as well, kind of related to the topic that the Loomlight team will be discussing. So keep an eye out for those here a little bit later. And as a reminder, we do publish the results of our polls into a piece we call a market check survey. So I'll share the results here with you in just a moment, but if you'd like to dig a little deeper and get our perspectives on these polls and how employers are answering them and kind of reacting to these topics, again, keep an eye out for that market check survey. All right, so my sneak peek for you, and this I don't think is a surprise, just over half of you are unsure on those Trump accounts. I think a lot of employers are still kind of evaluating this new bill and kind of what it means to them. Similar on the student loan. So let me share these results out with you. So it looks like a very small percent of you are intending to offer a Trump account. A good chunk of you are not offering it. And again, a fair amount of you are still kind of evaluating. And as far as the student loan, fairly similar numbers here. A few of you said yes. Most of you are saying either no or unsure. So again, we appreciate your feedback on those polls. And again, keep an eye out for some additional polling to happen during our presentation today. And with that, let's get into the presentation. Joining us from the Loomlight team, we have David Flotten, Brianna Barnett, and Amanda Olam. So team, I will hand things over to you.
Thank you, Jenny. All right, good afternoon, everybody. We do have three of us here today, and we got three sections we're going to cover. We will be starting with exactly what our poll questions were about, which is the OBBA. And in particular, obviously, this was a big, massive spending bill. We're focused, obviously, on the specific changes related to employee benefits. So I'll be taking that part up front. Amanda will then come in and talk about some changes to the employer shared responsibility penalties, penalty amounts, affordability percentages, some reporting changes. And then Brianna will wrap us up here with some other miscellaneous changes, several court cases, it's things like that. So we will cover all that stuff in an hour, but we will also try to answer as many questions as possible. So feel free to submit those, and hopefully between the three of us, we can answer as many as we can. All right, but let's get started and jump into the OBBBA, and in particular, the benefit changes that were there. So we're going to start with, there was a couple of changes specific to health savings accounts that are important, so we'll start there. So just as a reminder, if you have a health savings account plan, in order for employees to be able to put money into the HSA, whether employee or employer contributions, they have to be enrolled in a high deductible health plan, but they also have to not be enrolled in a non-high deductible health plan. They can't have any other coverage that's not an HDHP. Now, if we go back, say 5 years or so, 6 years, to prior to the pandemic, telehealth plans were disqualifying coverage, and that's because the way most telehealth plans are structured, you can call in to the telehealth provider and you'll get medical care without having to pay any contribution. The way we would have to get around that in order to be able to offer telehealth alongside an HSA, we had to charge what was called a fair market value fee, or an FMV fee, that every time somebody called in, they were supposed to pay this fee in order to be able to continue to make and receive HSA contributions. And you'd hear this referred to as a copay. It was not a copay. It was meant to represent what is the actual fair market value of this phone call to this healthcare provider. During the pandemic, Congress wanted to encourage people to use telemedicine to keep sick people out of doctors' offices and hospitals. And so they did a bunch of tweaks to telehealth. And one of them was they said temporarily, you can have telehealth with no cost sharing alongside an HSA, and it will not be disqualifying coverage. But it was temporary, and it actually expired a couple of different times, and then Congress extended it. And every single time we were sitting there wringing our hands, are they going to extend it again or not? And that happened most recently at the end of 2024, when the most recent temporary relief expired, and they didn't extend it. So for those of you with calendar year plans or plans that were renewed earlier in the year, you should have started charging a fair market value fee to your HSA participants in order to keep them HSA eligible. But now fast forward to the OBBBA, they decided, yep, we are going to extend this. And the really good news is they made it permanent. So it's not expiring and we're going to have to worry about this in another couple of years. It is now a permanent feature of HSAs that you can have a health savings account with no cost sharing, whether it's standalone or built into the HDHP, doesn't matter. And it will not be disqualifying coverage. Now, they did make this retroactive back to January 1st of 2025. So that does mean that you have a choice, particularly if you've got a calendar year plan, as to when you're going to implement this. Now, you don't have to implement it at all. You can continue charging an FMV fee if you want to, but I'm guessing most employers will want to get rid of that. And so the question is when, right? And you have several choices. You can change it now, mid-year, and say, okay, we've been charging an FMV fee up to now. Going forward, we will stop. You can also adopt it retroactively going back to January 1st, which would mean refunding any FMV fees that have been paid since the start of the year, but that would be acceptable as well. It's just more work. And I've heard several employers, this is what they intend to do, is to say, we're not going to deal with it now in the middle of the year. We will worry about it at the start of the next HDHP plan year. And at that point, we will eliminate whatever FMV fees we may have built into our telehealth. So this is actually our first kind of mid-webinar poll, is what is it if you have, assuming you're currently charging an FMV fee, which you should have been, when do you intend to eliminate it? Is it start of next plan year, now but prospectively only, or now retroactively back to the start of the year? So I'll give you a few seconds to answer that before we move on. Interesting. Very heavily weighted towards one particular answer. Quite a few people here today, so we will give it a little bit. Yeah, would have been an interesting question too to ask how many of you were actually charging the FMV fee, but I suppose we don't want to embarrass anybody or put them on the spot in a public webinar, although it is anonymous. I don't know who's answering what. All right, I think we're slowing down, so let's go ahead and end that and share it out. And surprise, a very large percentage, 80% of you are waiting. You're going to wait till the start of the next plan year, which, like I said, I've certainly heard plenty of that, but that's a very significant chunk who are saying we're just not going to deal with it in the middle of the year. We will wait till the start of the next year, and then we will get rid of it. So then, the now but prospective only, or 14%, only about 7% of you are willing to do a retroactive back to the start of the year. So very interesting. Thank you. Appreciate that. All right. Next subject, still HSAs, this time direct primary care. For those of you not familiar, a direct primary care arrangement is something offered by a healthcare provider, clinic, hospital, individual doctor, where instead of you going to see the doctor and they submit a claim to insurance, what you do is you pay a subscription fee, typically a monthly fee, that allows you access to a menu of various office visit services. And typically you get an unlimited number of those. It doesn't matter how many times you go in, you get whatever those covered services are as part of your subscription. Same problem as with telehealth is that that was a healthcare arrangement that was providing medical care with no cost sharing. Now, there was always some question of whether we could view the monthly fee as cost sharing, but the IRS's current thinking was no, those are really more akin to premiums. And so those direct primary care arrangements are in fact disqualifying coverage, and you would lose your ability to contribute to an HSA. So the OBBA is going to change that. This is prospective, so this starts January 1st of 2026. And it says that if you have a direct primary care arrangement, and it defines what that means, in particular, it defines what it is not allowed to cover. We're supposed to get more guidance from the IRS on this too, but for now, this is what we have. So it's got to provide primary care services, and that monthly fee can't exceed $150 a month for an individual, $300 for a family. Those amounts are indexed for inflation, so they can go up. So if you have a direct primary care arrangement that meets those conditions, whether the employer is paying for it, the employee is paying for it, you're sharing it, doesn't matter, it will not be disqualifying coverage. You can continue to make HSA contributions. The other related thing that they did was they actually clarified, and they said you can actually use your HSA money to pay those direct primary care fees. Again, it was never clear if you could do that. So it is now clear that at least HSA funds can be used to pay monthly DPC fees. Now, one thing that's important to note, that was an amendment specifically to the HSA statute. It did not amend Section 213D, which is the general section that talks about what's an eligible medical expense, which means that this does not do anything with respect to FSAs or HRAs. So if you ask me, can I use my FSA to pay my DPC fees? The answer is, well, not based on this. And based on the most recent guidance we have from the IRS, which isn't technically even official, the answer is no. So this is very specific to HSAs. So just keep that in mind. It does not open the door for FSAs or HSAs to reimburse those fees. And again, this is prospective, but it is also going into effect calendar year, so 1/1/2026. So even if you have a non-calendar year HDHP, your employees can start participating in these DPC arrangements right away on 1/1, and they'll be good from that point forward. Okay. So let me answer a question. What if the fee is $0 paid by the employer? Which is a fair question. It says there's got to be at least a periodic fee of up to $150 a month. It does not say there has to be a fee paid by the employee. It just says there has to be a fee. So it doesn't matter if the employer or the employee pays that fee, it still qualifies. Okay. Which actually leads to another interesting thought. So just as a bit of a tangent, if we talk about on-site or near-site clinics, they have the exact same problem as telehealth and direct primary care arrangements. The way they are usually structured, when an employee or family member goes to the on-site clinic, they usually get whatever their services are available with no cost sharing. Well, that's disqualifying coverage. And so historically, the way we have to get around that, if we wanted to have an on-site clinic and have HSA participants be able to enjoy it, they had to be charged an FMV fee. So a question to think about, though, is can I structure my on-site or near-site clinic in a way that it meets this definition of direct primary care? I'm not saying you always can. The answer may be yes and maybe no. It may depend on your vendor. But it is another way of thinking about making your on-site clinic HSA compatible. I don't want to charge an FMV fee, but if I can structure it as direct primary care, and it doesn't matter, again, like I just said, it doesn't matter if the employer pays them the monthly fee. If I can structure it that way, that's another way of making that on-site clinic HSA compatible. So it's at least something to think about and discuss, particularly if you're putting in an on-site or near-site clinic. Is this a new way we can get around some of that HSA disqualification problem? Just briefly to mention, remember I said to make an HSA contribution, you have to be enrolled in an HDHP. That is usually defined by the deductible and max out of pocket on that plan. They added this new provision that said for individual bronze and catastrophic plans purchased through the exchange, those will automatically be HDHPs regardless of plan design. But the important thing here is this is very specific to individual plans through the exchange. It does not apply to group plans offered by employers. So it's not like you can go out and get a bronze group plan and put it in place and say that's an HDHP. It only works for individual plans. So I just put it out there in case you see this and say, hey, that sounds like a neat idea. It does not work in the group market. All right, shifting off of HSAs, here's the other big news for employers is that they finally increased the annual limit as to how much can be put into a dependent care assistance plan, a dependent care health FSA, or not a health FSA, dependent care FSA, and they bumped it from 5,000 to 7,500. That number isn't indexed for inflation, so it's been stuck at 5,000 for years, and of course became slowly less and less valuable as inflation kicks in. So they've now finally bumped it up to 7,500. It's still not indexed for inflation. So in 10 years, we'll all be grousing the $7,500 doesn't get you very far. But at least for now, we do have that increase. If you're married, you don't get 7,500 each. You have to divide it between the two of you. If you're assuming both your employers have a DCAP, of course. The other thing, before we just kind of willy-nilly say, yep, we're going to raise it to 7,500, do recognize it's a lot of dependent care accounts, particularly with smaller employers, already have a very hard time passing non-discrimination testing. They simply can't get enough non-highly comped people to participate. Bumping it from 5,000 to 7,500 is only going to make that problem worse. Okay. So we'll have to wait and see what the numbers start to look like when the vendors start doing the testing. But I suspect we're going to see even more failures if you do go from 5,000 to 7,500. The other big issue here is that the DCAP, what the current limit, the 5,000, and the new limit, 7,500, are both calendar year limits. Okay, regardless of what your plan year is. The 7,500 cap applies on a calendar year basis. Now, if you've got a calendar year DCAP, that's no big deal. If you want to increase the limit, you just increase it on 1/1/2026. You will need to amend your cafeteria plan document because I can almost guarantee you that $5,000 number is hard coded in there. So you are going to have to amend that. But other than that, it's pretty straightforward. It's those of you who have non-calendar year DCAPs are going to have to stop and think, though, as to when you're going to do this, assuming you're going to do this, of course, as to when you want to implement this and how you implement it. The cleanest option is actually to wait. Don't implement it until your plan renews in 2026. Okay. If you really feel pressured or the need to increase the limit on January 1st, you can do that. But I would strongly encourage you to cap out how much they can increase their election. The problem is if you just jack it up to 7,500 1/1/26 and let them take advantage of the full amount, if they do that, they're going to have used up the amount of the 7,500 that they would need for the back end of the year, which is the start of your next plan year. And so they won't be able to make a full $7,500 election when your new plan year starts. So what you're going to want to do is cap it out so that the increase works out that they have $625 a month going into the plan for the remainder of the plan year. Okay. So just to give an example of what that would look like, assuming an October to September plan year, so you've got an employee who elects 5,000 October 1st, 2025, because that's all they can elect. They want to increase the election January 1st of 2026. All right, as of January 1st, they put in $1,250 so far from October to December. We want to limit them to $625 a month for 9 months, the remaining months in the plan year. So that's $5,625. So we add together what they've contributed, what the max we're willing to let them do for the rest of the year, and we get a new annual election of $6,875, or an increase of $1,875, not an increase of $2,500. Okay. As long as you do that, then when they come around to October 2026, they can now elect a full 7,500. If you let them put in more than that, you are going to have to do some math come October, figure out how much do they have left available to use the rest of the year, and they're not the rest of the calendar year, and they are not going to be able to make a full $7,500 election. So we would just strongly encourage you, if you're going to let them do it on January 1st, do this math, prorate it so that it gets spread out evenly throughout the calendar year, which does mean they're not going to be able to do a full $2,500 increase. Okay. Which leads to our last poll question here, which is, do you intend to do this? And if so, when? Do you plan on bumping your $5,000 limit to $7,500? And if so, are you going to do it right away in 2026, 2027 or later? We don't plan to do this, or again, we're not sure. Or somebody points out this assumes you have a decap. For those of you who don't have a decap, you could adopt it, right? So maybe it's unsure, but you're right. If we don't have a decap, then this is not going to be relevant to you. All right, slowing down here. So let's go ahead and end that. So not quite half of you do intend to bump it and do it in 2026. Some of you, a few of you, 3% are going to defer it. About 15% are saying we're not going to do this. And then about 40% of you are saying we're not sure yet, which, that's fine. We have some time. But obviously at some point a decision does have to be made. So. Okay. Last two things I've got, actually I got one more after this. Student loan repayments, we already touched on this in the poll question. This is just taking something that was temporary and making it permanent. It's been about 5 years that we've been allowed to do student loan repayments for employees and do it on a tax-free basis, but it was, again, sunsetted, I think at the end of this year, as in fact. But it has now been made permanent, and they took the $5,250 limit, which up until now has been like the decap limit. It wasn't indexed for inflation, and it is now indexed. So that's good news as well. That'll go up over time. The other temporary thing made permanent back in the day as part of the qualified transportation plan, you could have a component that reimbursed bicycle commuting expenses tax-free. That was suspended quite a while ago, but again, temporarily. It is now basically permanently. It's eliminated. So there are no bicycle commuting expenses, and they're not coming back at any point unless Congress changes their mind again. All right, last thing I just want to touch on, and I bring this up just because we've had a number of questions. There's a lot of misinformation floating out around there. Not everything that was originally included in the bill made it into the final version. So for example, there were a whole bunch of ICRA changes that were supposed to be in there. They did not make it into the final bill. So if you've got an ICRA, business as usual. There are also a bunch of HSA eligibility changes. Probably the biggest one was they were going to allow you to have Medicare Part A and still contribute to an HSA. That did not make it into the final bill. And there are several AI services out there that are saying otherwise, which is why we're getting a ton of questions. But just emphasize, no, you cannot have Medicare and participate in an HSA. You can contribute to an HSA. Right? So that continues to be disqualifying coverage. All right, I am going to hand it over to Amanda to talk about some ESRP changes.
David. All right. We're going to talk about the employer shared responsibility, the penalties that go along with it, who's subject to the potential penalties, and specifically, we're going to focus in on affordability. So just as a little refresher for you, so when we say the employer shared responsibility and specifically the penalties that go along with it, those penalties are applicable to applicable large employers, or ALEs, as you may have heard it called. An ALE is specifically an employer that averaged 50 or more full-time equivalents in the preceding calendar year. So for example, if an employer averaged 50 or more full-time equivalents in 2024, they would be an ALE in 2025. So one thing to keep in mind here, when we say averaged 50 or more full-time equivalents, you'll notice that we didn't just say full-time employees, right? So there is a component where you need to take into consideration more than just your full-time employees who are full-time for these purposes, 30 hours a week or 120 hours a month. The employees who work less than that still need to be counted. There is a specific calculation method that needs to be used. They need to be counted in some manner when determining whether an employer is an ALE. We also wanted to refresh you on how the penalties work under employer shared responsibility. So there are two penalties, A and B, named for the subsections of the law where you can find them. So the A penalty is the one that I typically refer to as the nuclear penalty, the penalty that you really want to avoid. Reason for that is if you are assessed an A penalty, it is assessed for each one of the employer's full-time employees for that month, even the ones that were offered coverage. By contrast, the subsection B penalty is only going to apply specifically to each employee for which the penalty applies. The other thing to keep in mind is that you cannot receive both an A and one or more B penalties in the same month. So said in another way, if you receive the A penalty, you will not receive any B penalties. If you don't receive the A penalty, you could receive one or more B penalties. So how do you get the penalties? Subsection A, you will be assessed if you fail to offer coverage to at least 95% of your full-time employees for a month, and one full-time employee goes to the exchange and gets a subsidy. And then the B penalty is specifically assessed against any full-time employee who was not offered affordable coverage that provided minimum value, and that specific full-time employee goes to the exchange and gets a subsidy. So the penalty amounts. You may be looking at this and thinking, why would you call the A penalty the nuclear penalty when it looks like the B penalty is significantly more expensive? Again, the A penalty is assessed for every full-time employee that was employed during that month if you are assessed the A penalty. So even though the number is smaller, it typically ends up being a lot larger if you are assessed an A penalty. Again, the B penalty is only going to apply if you had a specific full-time employee who actually worked full-time hours in a month, did not receive an offer of coverage, or they received an offer of coverage, but the coverage didn't provide minimum value, or the coverage wasn't provided at an affordable rate. That specific full-time employee goes to the exchange for their coverage and gets a subsidy. So the amount of the penalties are jumping up from 2025 to 2026. We have those penalty amounts listed there for you in case you are curious. We will now move on to talk specifically about affordability. So we have already really touched on one of the reasons that affordability is important. The first being that if you do not offer affordable coverage, you are at a much greater likelihood of ending up being assessed subsection B penalties for your full-time employees. The other reason that affordability matters is because when an individual goes to the exchange for their coverage, their eligibility for a premium tax subsidy is going to be based on whether or not they were offered affordable coverage by their employer. So those are the two reasons that affordability matters. In addition to those two reasons affordability matters, at the end of the day, we actually also kind of have two different definitions of affordability. So for purposes of an employer being penalized under subsection B, we're going to be looking at the affordability safe harbors. There are three of them. We'll kind of go over them in the next slide. But when it comes to whether or not an employee is going to qualify for a premium tax subsidy when they go to the exchange, the exchange is actually going to look at that employee's actual household income. As employers are not going to know their employee's actual household income, that is why the IRS gave us those three affordability safe harbors. Now, regardless of which version, which definition of affordability that we're talking about, we're always going to need to know the applicable affordability percentage, okay? And that is indexed and changes from year to year. We wanted to kind of go through this whole refresher and really bring your attention to the affordability piece of it, because the affordability percentage from 2025 to 2026 is increasing significantly. You'll see that in 2025, so for the current year, the percentage is at 9.02%. The percentage is increasing to 9.96% in 2026. So you may be asking, okay, when do I get to use that new percentage? Because it really is going to result in employers being able to charge quite a bit more for premiums for their full-time employees. That updated affordability percentage will begin applying for plan years that begin January 1st, 2026 or later. We also have a question here about whether affordability applies to dependents. So there is no requirement for employers to offer affordable coverage to their dependents, to an employee's dependents, but when it comes to whether or not the spouse and dependents will qualify for a premium subsidy on the exchange, there is an affordability calculation. But again, the employer does not really need to worry about it, because you will not be penalized if coverage is not affordable for spouse and dependents. Okay. So, like I said, we're going to specifically go through some of the safe harbors. So the first safe harbor is the federal poverty level safe harbor. This one is the easiest to use, and that is because it doesn't actually depend on an employer's employee wages. You don't actually have to look at how much employees are making in order to determine whether or not you qualify for this safe harbor. So this safe harbor is based on the federally determined federal poverty level. We have those amounts there for you in that calculation for both 2025 and 2026. And then you take that and multiply it by the applicable affordability percentage. Again, it's increasing pretty significantly to 2026, and then divide that total by 12. That's how you get the monthly rate. So for 2026, it is going up to $129.90. So if your 2026 rates are equal to that amount or less than that, you will be able to use that federal poverty level safe harbor, which is good news, and you won't even have to think about the next two safe harbors, the rate of pay and the Form W-2, both of which are going to require the employer to actually look at their employees' wages to determine whether or not they apply. So we'll start with the rate of pay. In order to use the rate of pay, you're going to take the employee's hourly rate, multiply that by 130, and then again, we're applying that affordability percentage which depends on whichever plan year we're in, right? You can also use the rate of pay safe harbor for employees who are salaried. And in that case, you're just taking the monthly salary as opposed to the hourly rate times 130. If you are using the rate of pay for hourly employees, you're always going to be using 130. That's the case regardless of whether the employee works more or less than that. The reason we use 130 is because that is the ACA's definition of full-time. So we have some examples here for you. For example, if you had someone who in 2025 was making $16 an hour, that would have allowed you to charge them $187.62 under this safe harbor. Taking into consideration that pretty large increase in the affordability percentage, that amount would be jumping up all the way to $207.17 in 2026. Moving on from the rate of pay safe harbor, the last that we'll discuss is the Form W-2. To use this, you're going to look at the box 1 wages on Form W-2, and multiply that by the affordability percentage, and again, change it to monthly amount, right? One thing I'll say about the Form W-2 safe harbor, this one is a little bit difficult to use for planning purposes. Obviously, you can't be sure what someone's Form W-2 will say in box 1 until it is actually generated until the end of the year. But the upside of using this one is if, for example, the rate of pay doesn't really work for you because under the rate of pay, you're not permitted to take into consideration tips or commissions, Form W-2 may be a better option for you. So again, just to kind of illustrate the point of how much this affordability percentage it could potentially affect you. If you look at the individual in our scenario making $40,000 in their box 1 wages, they're going up from $300.67 all the way to $332 in 2026. All right, we also wanted to mention to you the new Form 1095 distribution method. So again, as a little bit of a refresher, if you are an applicable large employer, you are required to prepare Forms 1094C and 1095C. The 1094C, if you'll remember, is essentially a kind of cover letter with employer information that goes on top of the individual 1095Cs, which include information about full-time employees, and then also just anyone covered by the plan if the plan was self-insured. When you file with the IRS, you're going to put the 1094C on top of those 1095Cs, send it all to the IRS. You are also required to take the 1095Cs and send them to the full-time employees or covered individuals. Prior to this new distribution method, most employers were just snail mailing those out. But we now have this new distribution method, which permits the employer to post a notice stating that the Form 1095Cs are available on their website. It's important to include here when I say on their website, the website where it's posted needs to be accessible to anyone who is supposed to be receiving that Form 1095. That doesn't always include only active employees. So if you're thinking of putting it on like an internal employee intranet, that's not necessarily advisable because, for example, if you had someone who terminated mid-plan year but was a full-time employee, is supposed to be getting that, they will no longer be able to access it if they no longer have those credentials, right? Or same goes for COBRA participants, or in the case of a fully insured plan. So again, a website where you don't have to have credentials to access it. That notice needs to include basically specific items where the individual will be able to look at that and get into contact in order to request the actual form. So it has to have the email address, physical address, and telephone number where they can request that Form 1095. And you need to ensure that that remains posted on your website until October 15th. Finally, in order to kind of round out this distribution method, in order to actually do it in a compliant manner, you have to make sure that the Form 1095 is provided within 30 days of request if it is requested. All right, this is my last slide, and then I'll pass it off to Brianna. So we just wanted to make you aware of this case, FAQ Company Inc. versus Becerra. Essentially what happened here is an employer was sent a letter to 26J. They were assessed an employer shared responsibility penalty. So again, for not offering enough coverage, not offering the right coverage. And they complained, stating they shouldn't have been assessed that penalty. And the reason that they stated for that is because they were actually never informed when their full-time employee went to the marketplace for coverage and got a subsidy. In the statute, the ACA statute, it specifically says in there that Health and Human Services is supposed to send notice to employers when that happens. The government's argument has been that the letter 226J, where the penalty is actually being assessed, is that notice, because it does essentially say in that letter, hey, somebody went to the marketplace and got a subsidy. But the court actually agreed with the employer in this case that they should have received a notice about that before they were actually assessed that penalty with letter 226J. So at this point, the court granted summary judgment and refunded that penalty that the employer paid. So the question we get now is, so what now for employers? Well, the requirements have not changed. Both the coverage and reporting requirements have not changed. So if you're an ALE, business as usual, keep offering coverage, make sure it's affordable, make sure you're offering it to full-time employees, do your Form 1094, 1095, send it to the IRS, send it to employees. But what this does is open up a little bit, maybe the options for employees who either have already paid those penalties, or for employers who get a letter 226J in the mail. It may be worth it to use this case as a reason as to why that penalty should not apply. I think, we have consultants that actually help with 226J assessment letters, and they have brought this argument up successfully. The other thing that I will say is that this whole defense, that you didn't get a letter from Health and Human Services stating that your employee went to the marketplace and got a subsidy, kind of rests on that you didn't get that notice. Well, if you live in a state, I think the only two right now are Minnesota and Washington, but where it is a state-run exchange and the state is sending out notices when this occurs, this whole defense kind of falls apart. But we'll see, because the federal government has filed an appeal, so it may go back to no longer mattering. However, if it goes all the way through and they decide that Health and Human Services should be sending these notices out, I think it will be a pretty significant burden for them to tackle, because at this point they are doing nothing of the sort. So we will keep you updated as we always do. But with that, I think I will pass it on to Brianna.
Thanks, Amanda. So in this third and final section, we're just going to explore some additional updates. So this includes changes to mental health parity enforcement, preventive care mandates, Medicaid eligibility, and other items that don't squarely fall within the OBBA bucket, OBBBA bucket or the ESRP bucket. So let's go ahead and dive into it. So first and foremost, mental health parity. So the Mental Health Parity and Addiction Equity Act, or MHP for short, applies to plans that offer mental health or substance use disorder benefits and are sponsored by employers with 50 or more employees. For non-federal government plans, the threshold is 100 or more employees, and it does not apply to accepted benefits or retiree-only plans. So just as a refresher, right, so MHP mandates that financial requirements and treatment limitations for mental health and substance use disorder benefits be no more restrictive than those applied to medical surgical benefits. So there are two specific categories of limitations that MHP specifies. The first are quantitative treatment limitations, or QTLs. The second are non-quantitative treatment limitations, or NQTLs. So QTLs include things like visit limits or cost sharing. So plans must determine if a QTL applies to at least 2/3 of medical surgical benefits. And if so, then they must apply the predominant level of that QTL, which means more than half, to mental health substance use disorder benefits. Now, NQTLs are more subjective, and they include things like prior authorization, provider network design, and medical necessity criteria. So there is no mathematical test. Instead, with NQTLs, plans must conduct a comparative analysis to ensure parity. So this is a very complex area, right? So documentation is key, and regulators are increasingly focused on enforcement, especially around NQTLs. So just to provide a historical overview of MHP and how the requirements have evolved since the 90s, beginning with 1996, the Mental Health Parity Act, MHPA. So this was the first federal law requiring parity, but it was limited to annual and lifetime dollar limits for mental health benefits. Then moving on to 2008 with the MHPAEA, the one we know so well, right? So this expanded the scope to include substance use disorder benefits, and it introduced the concept of parity in both quantitative and non-quantitative treatment limitations. Then moving to 2010 and 2013 with the interim rules in 2010 and the final rules in 2013. So these established 6 benefit classifications, and it formally defined QTLs and NQTLs. So this just laid the groundwork for how parity is measured and enforced. And then with 2016, we have the 21st Century Cures Act. So this required federal agencies to issue guidance on how to evaluate parity in NQTLs, recognizing the complexity and subjectivity involved in those comparisons. So fast forwarding to more recent developments with 2021, the Consolidated Appropriations Act, also known as just CAA, right? So this law amended MHP to require group health plans and insurers to perform and document a written comparative analysis of NQTLs. So this was a major shift, moving from a reactive to a more proactive compliance model. And then in 2024, most recently, we have the final rule. So this rule added several new layers of compliance. For example, the ERISA fiduciary certification. So plan fiduciaries must certify that the plan complies with MHP, adding a level of personal accountability in the mix as well. The second is meaningful benefits requirements. So plans must demonstrate that they offer meaningful access to mental health and substance use disorder services, not just token coverage. And then lastly, a data analysis requirement. So plans must analyze relevant data to identify disparities in access, such as denial rates, prior authorization burdens, and network adequacy. So these new requirements have not gone unchallenged. I'm sure you've heard of the pause on some of these MHP final rules from last year. So the ERISA Industry Committee, or ERIC, filed a lawsuit arguing that the 2024 final rule exceeds the statutory authority granted by MHP and imposes unreasonable burdens on employers. So in response, the court granted a temporary non-enforcement period. So this means that enforcement of the 2024 final rule is on pause until a final decision in the ERIC lawsuit is reached, plus an additional 18 months. And we're going to unpack that temporary non-enforcement a little bit deeper. So to clarify what the temporary non-enforcement actually means, the departments have announced that they will again not enforce certain provisions of the 2024 final rule until that ERIC lawsuit is resolved, plus 18 months have passed since that resolution. So specifically, the following are not being enforced. That's that fiduciary certification requirement, the requirement to demonstrate meaningful benefits, and the expanded data collection obligations. However, the core MHP requirements still remain in effect. For example, plans must still comply with QTL and NQTL parity rules. and plans must still perform and document NQTL comparative analyses. So this means that while some of the newer requirements are on hold, employers can't necessarily just ignore parity compliance altogether. So if anything, now is just a good time to review your plan's parity documentation and prepare for future enforcement potentially. Now, in terms of a Supreme Court case that is relevant to employer-sponsored health plans, we have Kennedy versus Braidwood Management, Inc. So in this case, the Supreme Court upheld the ACA's preventive care mandate, and this challenge just questioned whether the process used to determine required preventive services was constitutional. The court ruled in favor of the ACA, meaning that non-grandfathered plans must continue to cover preventive services without cost sharing. So this includes services recommended by the U.S. Preventive Services Task Force, the Advisory Committee on Immunization Practices, and the Health Resources and Services Administration. So employers should just continue monitoring updates from these panels and ensure their plans are updated accordingly. So again, no changes are required at this time, but this ruling just reinforces the importance of staying current with preventive care guidelines. Getting back to the ACA in terms of some 2026 payment parameters. So the ACA's maximum out-of-pocket or MOOP limits for 2026 have been updated due to a change in the formula used to calculate them. So originally the 2026 MOOP was set at $10,150 for individuals and $20,300 for families. Under this new formula, those limits have increased to $10,600 for individuals and $21,200 for families. So it's also important to remember that ACA MOOP limits must be embedded if the family MOOP exceeds the individual limit. So for example, if the 2026 family maximum out-of-pocket limit is above $10,600, the plan must start to pay if any individual within that family unit incurs $10,600 in medical expenses. So again, employers should just review their plan designs to ensure compliance with the new limits and confirm that embedded MMOPs are included properly. So there have also been changes to Medicaid, right? So the One Big Beautiful Bill Act introduced several changes to Medicaid. These include the implementation of work requirements. So beginning in 2026, able-bodied adults will be required to complete 80 hours per month of work, volunteering, and/or some form of education to maintain Medicaid eligibility, with some exemptions such as pregnant women and the elderly, as well as more frequent eligibility redeterminations, and the elimination of eligibility for undocumented individuals. So what does this mean? These changes are expected to result in a significant number of current Medicaid recipients losing coverage. And importantly, the loss of Medicaid eligibility qualifies as a HIPAA special enrollment event. So employers should be prepared for a potential increase in group health plan enrollments as a result when they seek alternative coverage. Additionally, the temporary increase in premium tax credits is set to expire at the end of the year. So this may make individual market coverage less attractive, further driving enrollment in employer-sponsored plans. And so I'm going to pass it back to David and Amanda to see if we have any other questions before closing out.
Thanks, Brianna. I did answer several of these, but we did have several questions when it comes to the 1095 alternative distribution rule and like variations on the theme. Can I post it on my payroll website? Can I post it on my internal website for these people and mail it to those people? Can I do, basically, do I have to do it on a public website? The answer is yes, you have to do it on a public website. You will not satisfy that alternative distribution method if you put it on a payroll site, if you put it on a benefit enrollment site, if you put it on an intranet. Even for those people who have access to it, it does not satisfy that alternative method. So basically, you have three options to distribute your 1095. You follow the alternative distribution method, which means it goes on a public website. You mail it. Or we had several people ask, can I email it? Are there other ways I can distribute electronically? You can distribute 1095s electronically, but you have to get specific written authorization from the individual. So if I want to email Amanda her 1095, Amanda has to sign off and say, I agree to that. Okay.
Yeah.
So it does not work very well, particularly for large employers and particularly for former employees or ex-spouses or whatever.
And you may already be getting like authorization to send things electronically, but a lot of times that statement just says something like, can we send you forms that ERISA requires us to send you? For this, you have to say specifically, can we send you the form 1095C, right?
And along the same lines, you may have an authorization to send the W-2 electronically. That's not good enough either.
Yeah.
Now you can combine them. You could do an authorization that says you agree to send the W-2 and the 1095, but an existing W-2 authorization, electronic distribution authorization, won't cover the 1095. Okay.
Yeah.
So those are your three options for distributing the 1095. Brianna, somebody's asking, are the OOP max limits limited to in-network benefits?
Yeah, so they do only apply to in-network essential health benefits. So yeah, this includes, deductibles, co-payments, co-insurance, but not premiums. So they are limited to in-network.
Okay. With regards to so somebody asking about Medicare changes. What we were talking about was Medicaid changes, not Medicare. So the question was about notices. I mean, yes, the states will provide Medicaid recipients with notices. If history is any guide, not in a very timely manner, but they will eventually tell them, yeah, you're not eligible, or you have to have this work requirement, whatever the case may be. We'll see. It could be a bit of a mess because they've not exactly historically shown very good skills at getting those notices out. Let's see, what else? I think that's it as far as I think things that are pertinent to what we've had here today. Jenny, do you have any final comments?
Hey guys, thank you so much. You guys covered so much ground today. We had lots of great questions from the audience. So thank you to our audience for tuning in and for all of your great questions. If we didn't get to your question or if you wanted to dig into this further, please do reach out to that benefits advisor who invited you here today. They will be able to help you get any remaining questions answered. And as a reminder too, that benefits advisor is who you want to reach out to if you are looking for a link to the recording of today's session, if you want to revisit the content or share it with a colleague. Again, reach out to the benefits advisor who invited you here today. And again, we just want to extend our thank you to those benefits advisors and consultants who are partners of AssureXglobal for making these webinars possible. Thank you again to Brianna, David, and Amanda. Thank you again to our audience for tuning in. That does conclude our time. Have a wonderful afternoon.